So, anemia is the condition where your overall oxygen carrying capacity is reduced because of a low level of effective hemoglobin molecules in the blood. Now, this will be one of two videos that I'll be using to go over anemia and my thought process for the workup of anemia. And first, we're going to start off with a common theme in medicine where a lot of things can be explained by a thought process of accumulation equals input minus output, where accumulation in this case would be the hemoglobin molecules, and that depends on the level of red blood cell production, as well as the output, which would be any kind of destruction of red blood cells or any bleeding, so regular just loss of red blood cells. And since we're talking about an anemic state, this will be where the accumulation of hemoglobin is low, and this can be produced by a low red blood cell production without any bleeding or destruction. It could be caused by a state of simply increased bleeding or increased destruction of red blood cells, or it can be a combination of both because of a decrease in red blood cell production and an increase in bleeding or destruction. Now, in this video, we're going to focus on the input problem aspect of things, where there is a decreased red blood cell production and how we tease out whether or not this actually exists as part of the problem of anemia is by using something called the Reticulocyte Index. And to put simply, the Reticulocyte Index is a term we use to compare the body's state of current anemia and comparing it with the bone marrow's red blood cell production rate. And by comparing these two, we can kind of see how hard the bone marrow is working to address the state of anemia. And by looking at the comparison, we can kind of tell whether or not the body is appropriately or not appropriately responding to the state of anemia. Now, if the body is quote unquote appropriately responding, then that would mean that there is no production issue. If the reticulocyte index is low, that would suggest that there is some sort of production issue going on where the processes to produce more red blood cells to address the anemia is blunted for some reason, and that is the overall cause of the anemia. Now, in terms of the specific details of the reticulocyte index, it can be expressed with the following formula, where it's the actual hematocrit over the expected hematocrit multiplied by the reticulocyte percentage divided by the reticulocyte maturation time. Now, you can see that the first term, where the degree of anemia is represented by the actual hematocrit over the expected hematocrit, just compares how anemic is this person compared to normal. Whereas the reticulocyte percentage, which we'll get into a little bit later, is representing how hard is the bone marrow working to push new red blood cells into the peripheral blood. So first, I just wanted to give a quick example of the reticulocyte index in a non-anemic individual, where the actual hematocrit is about 40% and the expected hematocrit is also about 40%. And if you were to get lab values on this non-anemic individual, their reticulocyte percent or reticulocyte count would be about 1%. And we'll get to later about how we determine the reticulocyte maturation time, but it's about 1 day for anyone who has an hematocrit of about 40%. So the reticulocyte index calculates out to be about 1%, which is normal for someone in a non-anemic state where the reticulocyte index should range somewhere between 0.5 and 2.5. But it's easier to just remember 1%, so I think that's something we can use as a reference. In a state of anemia, however, the reticulocyte index should increase. So let's say, for example, a realistic example would be someone with a hematocrit of 20%. If you get lab values on this individual, then you'll find that the reticulocyte percentage may vary a little bit, but let's say for this example that their reticulocyte percent is about 8%. And again, we'll get to later why we know that that would correspond to about 2 days of reticulocyte maturation time for someone with a hematocrit of about 20%. But you'll see that if you were to calculate all of this out, the reticulocyte index would be about 4%. Now, if you were to try to evaluate whether or not this is an appropriate response to the state of anemia, if the reticulocyte index is above 2 to 3%, then that means that there is not a production issue going on. And just for some context, the reticulocyte index can go as high as about 8%. So I went through all of that calculation pretty quickly, so I just wanted to go over it one more time of the anemic individual. So an anemic individual without any production issues, the blood work would kind of look like this. we'll have to plug in this other number called the reticulocyte maturation time to calculate the reticulocyte index. And you may be wondering, like, what the heck is this reticulocyte maturation time adjustment factor for the reticulocyte percentage, right? So we want to compare the degree of anemia with how much the body is producing red blood cells within a single day to address that state of anemia. The problem is, as our body becomes more and more anemic, our body's response pushes out more and more younger reticulocytes that take a longer time and to mature into red blood cells and thus stay in the peripheral blood as reticulocytes for longer. Now, there's a convenient way in order to determine the reticulocyte maturation time based off of the degree of anemia, and you can see that based off of the hematocrit. So if we look at this table here, you can see here, depending on the hematocrit, 40%, 30 to 40, 20 to 30, 20% or below, you can see that the reticulocyte maturation time increases little by little. So if we were to look at, for example, the 20 to 30% range of the hematocrit, at that point, if the bone marrow is working properly, the reticulocyte maturation time should be about 2 days. And that means if we see a reticulocyte amount in the blood, about 1/2 or about half of the reticulocytes seen were actually produced in the past 24 hours, which is what we're interested in. If we look at another example, if the hematocrit were somewhere between 30 to 40%, the maturation time is about 1.5 days. So that means of whatever reticulocytes we see, about 1/1.5, or about 2/3 of the reticulocytes seen were produced in the last 24 hours. If we take a normal individual with no anemia, with a hematocrit over 40%, then the reticulocyte maturation time is about 1 day, which means all of the reticulocytes you were seeing were produced in the past 24 hours. So essentially, if we were to see in this case a reticulocyte percentage of 8%, and we see that the hematocrit is about 20%, that means that about half of those reticulocytes have been in the blood since yesterday. The other half, or about 4%, are the reticulocytes that represent the reticulocytes that have been newly introduced into the blood. So let's say we get these values where the hematocrit is about 20% and the reticulocyte percentage is about 8%. If we go through the whole calculation of the reticulocyte index, we'll find that the reticulocyte index is approximately 4%, which is greater than the 2 to 3% we discussed earlier. So that would suggest that there's no production issues, and thus we can kind of rule out any kind of red blood cell production issues leading to the anemia and move on to the second part, where there may be an increased output, which means a increased destruction or increased bleeding that is causing the overall state of anemia. But let's say instead of the reticulocyte percentage being about 8%, we find that when we draw blood on this person, we find that the reticulocyte percent is about 4%. Now, if we were to plug everything in, then we would find that the reticulocyte index is only about 2% despite the state of anemia. And as we discussed earlier, if the reticulocyte index is not greater than 2 to 3% in the state of anemia, then we can pretty accurately predict that there is some sort of production issue going on that is preventing the body to appropriately respond and push out the appropriate number of red blood cells into the blood. Let's say that we do find that there is a production issue and the reticulocyte index is low. Then we have to differentiate between the several different types of production issues. And that could be determined by looking at the mean corpuscular volume or the size of the red blood cells that are produced. These are broadly divided into 3 separate categories. One is microcytic, where the mean corpuscular volume, or MCV, is less than 80. The normocytic, where the MCV is about 80 to 100, so about the normal range for red blood cells. Or macrocytic, where the MCV is greater than 100. So first, with microcytic anemia, that's when the MCV is again less than 80, is a category that I think in my head as not enough hemoglobin molecules in the red blood cells, which leads to the small red blood cells. Now, this category in of itself can be divided down into another set of subcategories of iron deficiency anemia, anemia of chronic inflammation, or thalassemias, or sideroblastic anemias. So to differentiate between these subcategories, we need to get some additional labs, including the serum iron, the ferritin, transferrin, and total iron binding capacity. So I wanted to just go over each of these very quickly. So the serum iron, as its name implies, is just the iron in the serum, as well as the ferritin is actually like a molecule that holds iron intracellularly. So it kind of represents like the iron stores in our body. The transferrin is a molecule that holds iron in the intravascular space. So it actually acts as like a proxy of the body's intention of what it wants to do with iron. So for example, if the transferrin is very high, you know that the body's intention is that they want to grab more iron from our diet and hold on to more iron. Whereas if the transferrin is very, very low, that means it wants to keep the iron out of the intravascular space. And we'll get to why in certain situations the body may want to do that. So the total iron binding capacity and the transferrin saturation kind of go hand in hand in that the total iron binding capacity is how much free transferrin is there in the blood such that the body can bind more iron, as well as the transferrin saturation kind of tells you how much of the transferrin in the blood is already occupied with iron. So as the total iron binding capacity goes up, the transferrin saturation is probably going to go down, and vice versa. In a state of iron deficiency anemia, there's simply just not enough iron to produce the appropriate amount of hemoglobin. So understandably, our serum iron would be low. The intracellular iron storage, or the ferritin, would also be low. The transferrin, or the molecules trying to hunt around to find more iron to grab to create red blood cells, is high. And the total iron binding capacity is also high because the body has a lot of those transferrin molecules roaming around that have a high capability of pulling in a lot more iron. But again, the saturation of the transferrin is very low. In states like anemia of chronic inflammation, we have a state where our body is trying to keep the free amount of iron low in our blood so that other things don't have access to it to further harm the body. So one concept that really helps to understand this is that if we have other pathogens in our blood, like bacteria, they really love to have iron because they themselves need some iron to carry out its metabolism. And thus having a iron-rich environment is very beneficial for those pathogens. So if we have a chronic state of infection going on, our body has developed this mechanism to reduce the amount of free iron available floating around in our blood to blunt the ability of these pathogens from benefiting from iron-rich environments. So our serum iron would be low. Our ferritin, or our intracellular iron storage, would be high because our body's trying very hard to keep iron within our own cells and not make it available for other things to take it up. And our transferrin and total iron binding capacities are low. And again, our transferrin is low because we don't want many molecules out there that allow for iron to be kept in the extracellular space that well. And as a result of that, the total iron binding capacity is also low because the amount of transferrin in our blood is also low. In the case of something called Sideroblastic Anemia, the issue is that we may have enough iron in our blood, but for some odd reason, we're not able to process it, or the process of using that iron to create hemoglobin is blunted somehow. The classic example for this would be something like lead poisoning, where the lead interferes with the hemoglobin production process despite the adequate amount of iron in our body to produce the hemoglobin. So in this case with lead poisoning, we would see that the serum iron may be high or appropriate levels because again, there is no iron supply issue. The intracellular iron storage represented by our ferritin is also high because there's like a backup of iron in our cells that's waiting to be put in to produce hemoglobin, but are stuck there because there's some sort of inhibition in the way. Our body's not necessarily craving for more iron, so our transferrin is low, so we're not really necessarily hunting for more iron to be brought into our cells. So by looking over these lab values, we can kind of differentiate between iron deficiency anemia, anemia of chronic inflammation, also known as like anemia of chronic disease, as well as sideroblastic anemia. The last odd one out would be Thalassemias, where again there is a production issue of hemoglobin because some of the instructions to create the hemoglobin molecule are defective, so some of the pieces to produce the hemoglobin can't be used, and thus the hemoglobin production is very low. In thalassemias, we actually see something where the mean corpuscular volume, or the MCV, is remarkably low, like below 70. So whenever we are suspecting of maybe a thalassemia being in the picture, you can calculate something called the Mensur index, where that's the mean corpuscular volume divided by the red blood cell count. And if the Mensur index is below 13, that is a characteristic of thalassemias, where the MCV is very, very low. Now, what the Mensur index is trying to do here is basically differentiate between an iron deficiency anemia and a thalassemia. In the case of iron deficiency anemia, the red blood cell count itself tends to go lower, so decreases, and thus the Mensur index would be higher. In the case of thalassemias, the red blood cell count itself may not actually increase that much, thus keeping that ratio below 13, which is the characteristic of thalassemias. So to summarize what we talked about so far, if we have a state of anemia and a reticulocyte index that is less than the 2 to 3% response to that state of anemia, and if we find that the red blood cells in this state of anemia are microcytic or have an MCV less than 80, then we can narrow it down to iron deficiency anemia, anemia of chronic inflammation, sideroblastic anemia, or thalassemias. And you can use the serum iron, ferritin, transferrin, TIBC to differentiate between those different types of microcytic anemias. The next one we'll talk about is macrocytic anemia. So again, same story. We have a state of anemia, we have a reticulocyte index that is inappropriately low for the state of anemia. However, this time our MCV is greater than 100, and that's more usually a DNA synthesis problem. And what I mean by that is that while our red blood cells are being produced, they have some DNA to begin with, and for the DNA production process, just like any other cells, they need the proper materials and cofactors and everything to produce the proteins necessary to function normally. Now, in cases like folate deficiency, B12 deficiency, or any drugs that inhibit any of these factors like folate or B12 from appropriately helping out with the DNA synthesis, we end up with a situation where our DNA synthesis is blunted or slowed down. So as the cell is working to create the DNA necessary, the cytoplasm of the red blood cell keeps on growing and growing and growing and waiting for the DNA to be fully produced and copied. So by the time that the DNA is fully copied and synthesized, the cytoplasm has basically like ballooned out into this huge thing because it took a really long time for the DNA to complete. So the typical workup for macrocytic anemia is to simply get the lab levels of the common culprits of macrocytic anemia, which include low B12 and low folate levels. So you would get both of those levels to see what it's like. It's also worth getting an investigation on the medications that the patient is on, which may be contributing to the causation of the macrocytic anemia. And now the last category of production issue related anemias is a normocytic anemia, where the MCV is actually normal to regular red blood cells. And in these cases, I categorize this in my head as a quote unquote not enough space problem, or basically not enough space to produce the red blood cells. What's important in this case when you have a normocytic anemia is that you want to kind of evaluate to see if there are any other cell lines down. And that may point to any kind of myelodysplastic syndromes or myelofibrosis where there's physically less space for red blood cell production in the bone marrow. And thus, the red blood cells being produced may be of normal size, but because the factory itself that's producing the red blood cells is constrained, the production rate is very low. But in any case, with all these different types of normocytic anemias, something that may be helpful to evaluate the difference between those is getting a bone marrow biopsy to really see what's going on there at the production site. And with normocytic anemias, it's important to note that you want to also consider the pathologies that can be categorized as microcytic anemia because it may be normocytic right now, but it may be on the way to becoming a microcytic, and you might have caught an early phase of a microcytic anemia pathology. So again, to summarize, anemia is overall a decrease in oxygen carrying capacity because of a decreased amount of hemoglobin in our blood, and that can make us feel very tired. But in any case, one of the key tools to start evaluating states of anemia is using something called the Reticulocyte Index, which tells us whether or not there are any production issues going on. And if there are, then we can further investigate whether or not it's a microcytic problem, a macrocytic problem, or a normocytic problem. Now, in clinical practice, we'll often see ourselves going straight to getting some iron studies and evaluating microcytic anemia problems because the most common type of anemias that we see are iron deficiency anemias or anemia of chronic inflammation. And thus, if we see a microcytic anemia, we don't necessarily evaluate for the reticulocyte index and then go through this whole process of seeing if there's a production issue first. But just in terms of a learning point, the assumption that we're making when we skip to getting those iron studies is that we're assuming that there is a production issue underlying it first, and then jumping to evaluating for the microcytic anemia. And I'll be producing another video that goes over the second part of an output issue where there's increased destruction or increased bleeding. I hope that was helpful, guys. Bye.